Thank you very much for the invitation, and it's really nice to be here to meet people without boxes around their heads. So I think we've learned that surgery is the key potential curative treatment. However, less than 1 out of 6 patients are amenable to have surgery, and ultimately only a third or 40% of these patients goes to have resections. And if patients are inoperable, we use systemic treatment, and that's, unfortunately, invariably, this leads to resistance. The other aspect we have to consider is that a large number of patients with cholangiocarcinoma die because of tumor-related liver failure related to the tumor growing in the biliary tract or the vessels and causing jaundice. So we're thinking radiation could be an option for local treatment. And just a quick summary that radiation is a non-invasive form of local regional treatment, and we think it may play a role in the curative and palliative setting. But because this is a rare cancer, we are struggling to acquire high-level evidence to support radiotherapy. There is so much more now than 10 years ago about molecular characteristics of cholangiocarcinoma. So hopefully in the next decade, or earlier I hope, we will understand better if there is a non-metastatic phenotype where local regional treatment could be useful. And finally, we think very high dose radiation can control cholangiocarcinoma. I'm just going to show you a couple of slides on current technology available to deliver radiation. And we have now what we call intensity modulated radiotherapy, where we can dose paint the tumor. So what you could see in the picture is a patient I've treated in the ABCO trial with John. It's a very large cholangiocarcinoma, and you can see we spared the liver quite well. And this is the result after radiotherapy. The tumor has shrunk, and there is a bit of peri-liver ascites, but the patient is well. Particle therapy and proton beam therapy spares the liver parenchyma more, so we think that patients with liver malignancy would benefit from this sort of treatment. And on the left-hand side of the picture, you've got a patient which was treated with proton, and on her right-hand side of the picture at the bottom is somebody who received intensely modulated radiotherapy. And you can see the blue is the dose washout. So we are, with protons, you definitely spare more than normal tissue, which is important to be able to deliver systemic treatments. So there is some sort of philosophy emerging that tumors away from the hilum and vessels, which are quite sensitive, are more suitable for a stereotactic ablative radiotherapy, where extrahepatic tumors are more suited for standard or hypofractionation. So what is the data we have about radiotherapy? There's very little data. There is no level 1 evidence, and we shouldn't make analogies with pancreatic cancer of hepatocellular carcinoma. The data quality varies, and this is a theme which is repeating across the conference. We have single institution or retrospective databases. And only recently we started to look at patients differently, separating hilar, distal, and gallbladder cancer. However, we know a group of patients have a local regional pattern of failure. We know the survival is poor, and radiation can maintain local control. When we use radiation, in general, the recommendation is to sequences after systemic treatment. And I'm just going to show you quickly two pieces of data, one from MD Anderson, so it's North America, where they looked at 79 patients with inoperable cholangiocarcinoma with quite large tumors, nearly 8 centimeters, where a dose of 80 gray, so remember this number, 80 gray was given. And what's interesting The patients who have doses more than 80 gray, which is the blue line on the survival curve, and local control seem to do a bit better. And I've done something which Juan won't be happy with. I put the GEM-CIS curve from ABCO2 there just to show you a difference. So we think the radiation is a key significant factor. And this is the other second study we have, which is a prospective phase 2 study with proton beam therapy, where they were 37 intrahepatic cholangiocarcinoma treated, which it showed that the local control at 2 years was 94%, and the overall survival at 2 years for intrahepatic cholangiocarcinoma was 46%, with less toxicity than protons. So our US colleagues have done a similar sort of look at the population treated in US from 2004 to 2018 with biliary duct malignancy. And what's interesting, of the 37,000 patients they were diagnosed with code C221, which I think it's a mixture of everything, 42% of patients had no definitive treatment, 45% had systemic treatment, and only 13% of all patients had radiotherapy. So similar numbers to UK in terms of chemotherapy and no treatment. But what's interesting, more than 1,000 patients had radiotherapy, and there were conventional radiation and ablative radiation. So this is the 80 gray I mentioned. There was no change in frequency of the use of the radiation over the decade they looked at, but there is a noticeable increase of patients who receive ablative radiotherapy. And there was enough data for more than 1,000 patients to look what the outcomes were. A third of the patients received proton therapy. The median survival of the patients who receive ablative radiotherapy was nearly 2 years compared to conventional radiotherapy, which was 1 year. And the 1 year and up to 3 years overall survivors appear to be better with ablative radiotherapy, but still needs improving. And this is the survival curves. And we can see there is a tail of about 25% which are alive at 5 years, which is infer that if radiation is delivered, this should be in the form of ablative radiotherapy. There's also similar data in patients with metastatic disease. And what I'm showing that if you have systemic treatment with some liver-directed therapy, whether surgery or high-dose radiation, there appears to be a slightly better survival. Now, how can we select which are the patients which are sensitive to radiation? There's very little data and whether we should or should not use a radiation sensitizer or who should be receiving radiation. The only data I found is from MD Anderson, where they had looked at 156 patients who were with inoperable intrahepatic cholangiocarcinoma, of which 114 patients had genome sequencing they had their molecular profile. Again, tumor size around 7 centimeters, and the radiotherapy dose given was 98, the mean rate, so ablative dose is 80. There is a median follow-up of nearly 5 years. And 80% of the patients had systemic treatment with cisgem, and some of them have chemo after, but there's no details. The landscape of mutation is similar to what we expect in intrahepatic cholangiocarcinoma, with 25% of the patients being IDH1 mutant. But what's interesting, the 1 year overall survival differ depending on the mutation you have. With FGFR, 2 patients seem appearing to have a better survival or local control, but this is at 1 year after radiotherapy, but this is sort of observational data. The reason I put this forest plot from this paper, it's interesting because it seems to be there is a large number of patients with metastatic disease which are receiving radiation. And at the moment in UK, we hardly use any radiation for metastatic disease, and there's something I'm keen to explore further. These are the survival curve, and at the bottom, panel C and D, it shows, panel C specifically shows you that IDH mutant appears to not to do so well after radiation, in the same for PI3 kinase mutant. But these are just hypotheses generating. There is very little data about immune treatment and radiation, and this, a lot of people are asking me, should we combine this? The only data I have is a match pair analysis looking at inoperable or recurrent biliary tract cancer, of which 20% were ampulla and gallbladder. And the match pair analysis looked at chemotherapy alone, cisgem, which is standard of care, or a cohort of patients who had de novo radiotherapy followed by a PD-L1 inhibitor. Most of the patients, all of the patients completed radiotherapy and the median 8 cycles of IO. And in terms of chemotherapy, the average number of cisgems was 5. What's interesting, there were hardly any toxicity in the radiotherapy and IO group, which I find difficult to believe. With 79% of the patients having grade 3 and 4 toxicity in the chemo group. I'm sorry, the figures are a bit rubbish, but really what it shows that if you have radiotherapy and IO, the median survival was 17 months versus 11 months just with GemCis, with a better DFS. This is intriguing data because the systemic treatment was not used at all. It was just radiation and immune. But we just need to understand how to select patients to receive different treatments based on the molecular signature. So lastly, what are the prospective and ongoing trials? In terms of the perioperative setting in a transplant, we are doing the service evaluation in UK, but there is the French study, TransField study, which is a randomized control study. We have, so these are trials just about for radiation, just so it's clear. We have nothing in the adjuvant setting, and in the locally advanced setting in UK, we've got ABC07 trial. We've tried to do radiotherapy in the positive margin patients post-operatively, but we haven't received funding to do that, so that trial is now going no further. The ABC07 study, which opened 8 years ago now, we are due to complete recruitment this summer, and we've nearly recruited within another, I think 5 patients or 6, if my maths, I don't know, my maths is not good, 7 patients to complete recruitment. But this is the only study where we'll have randomization where the radiotherapy, in addition to systemic chemotherapy, improves progression-free survival. So at the moment, we are sort of a bit stuck about future trials involving radiation because we have difficulties to reach a consensus. We don't know which patients we should be using protons. We still don't know how to incorporate radiotherapy in the perioperative setting and the molecular stratification. So in conclusion, I would say that the role of radiotherapy is increasing. And I want to thank you very much for supporting the ABC07 trial. We think that cholangiocarcinoma is sensitive to radiation, and especially high-dose radiation. We need to work closely with the biologists, the medical oncologists, and surgeons, not to leave them out, to identify how to select patients and patients who benefit from a local regional treatment. And lastly, we still don't know how to sequence and combine treatments. Thank you.